second-year cardiology resident at JJ Hospital, and today I'll be discussing a dual hardware entrapment bailout technique that we did for a complicated case. While it's not often that we see this, but every interventionalist should be prepared for when it comes their way. A 53-year-old gentleman came to us, a known case of type 2 diabetes mellitus with a history of alcohol use and tobacco use, came with progressive breathlessness of NYHA class 2 progressing to NYHA class 3 and chronic stable angina. He had history of old ischemic heart disease and had undergone PCI with 4 drug-eluting stents, 2 LAD, LCX, and OM. We did a repeat coronary angiography for him, which, as seen, shows 80% osteoproximal de novo lesion in the LAD before the prior stent, and a diffuse 80% in-stent restenosis in the dominant LCX. Our initial strategy was simple. We planned a dual vessel PCI, targeting and tackling the in-stent restenosis in the dominant LCX first, and then targeting the de novo lesion in the LAD. However, we faced a hiccup right at the start. During the check shoot at the beginning, we noticed that there was a suspicious underinflated proximal portion of the stent with significant coronary calcium, as can be seen in the animated diagram. So we had to do some essential amendments. We did balloon dilatation with a non-compliant balloon at the proximal end of the stent to achieve optimum strut inflation. During the next step, while advancing the stent, we faced our first roadblock. While advancing the stent, we noticed that there was a lot of tortuosity and calcium. The stent tried to be maneuvered to the desired location, but it could not happen. We gave gentle traction to the stent to and fro to reposition the stent, but again, we couldn't do it. So we tried a buddy wire. We took a buddy wire, advanced it alongside to assist furthering the stent, but again, that could not be done. Another Fielder FC wire was parked in the LAD and balloon inflated over it in LAD to provide additional support to the LCX stent to course ahead, but again, that was unsuccessful. Our last attempt was with a guideliner, but it was futile. So the next step that we tried was to completely retract the previous stent and put in a new one, but we failed again. Any further manipulation would have deformed or dislodged the previous stent. So now we were facing a stark reality that our stent was trapped. So what we did was, stent was inflated in the unintended position in LM-LCX. That stent expanded well, which was confirmed on the check shoot. But our woes were not ending. We faced a second roadblock immediately after that. The stent balloon, which was deflated, it could not be retrieved. So we tried to troubleshoot it. We used the anchor balloon technique, where we sequentially advanced a buddy wire along the entrapped balloon, and over it, we also advanced a small-sized anchor balloon of 2 into 8 millimeters, just distal to the trapped balloon, inflated at low pressure up to 6 atm, creating an anchor point. This anchor point ensured that the deflated balloon dislodged from the stent, and we were able to pull the entire assembly en bloc. But now, even though we had successfully retrieved our hardware, we had to treat the patient. We had a sudden change of plan just because of an unintended position of the stent inflation. So now, which was a simple dual vessel plasty, we had to convert it to a bifurcation plasty. The lesion in LM-LAD was stented with a drug-eluting stent, and an LM-LAD bifurcation, LM-LAD LCX bifurcation with a Q-load technique was done. Final kissing balloon inflation to reconstruct the carina was done. Such difficult cases give us major takeaways. Stent and stent balloon entrapment are rare, and both together are even detrimental complications encountered during percutaneous interventions. They can occur during any time, during the delivery or post-dilatation, posing risks to vessel injury, stent deformation, coronary dissection, and acute vessel occlusion. This case highlights the mechanisms, clinical implications, and stepwise techniques used for successful retrieval. There are multiple strategies, some are listed below, like prolonged negative suction with indeflators to facilitate deflation for an inflated stuck balloon. Use of a second guide wire or a buddy wire to improve support and manipulate the balloon shaft like we did. Balloon puncture techniques using microcatheters, stiff wires, or cutting balloons to decompress trapped balloons. A snare-assisted retrieval in cases of retained fragments, and the last resort, an emergency surgery. In our case, prompt recognition and systematic application of percutaneous retrieval techniques deferred surgical intervention. We achieved a TIMI 3 flow without any dissection, and the patient was hemodynamically stable. Presence of mind and operator skill helped convert a complication into a bailout bifurcation plasty to safely combat stent and balloon entrapment without any consequences. Every catastrophe teaches us something. Here we learn that stepwise structured approach of retrieval avoids vessel injury. We must adapt real time when the plan changes. Preparedness with bailout techniques as a backup is a must for every interventionalist.
Do you have last shoot? Do you have last shoot of, because you didn't show the ceiling actually?
It was just a stent boost
Yeah,
image.
just you showed the stent boost, nothing. We want to see the, actually what happened to that circumflex stent actually.
I don't have the last shoot at this
Because that's the
present
most
moment.
important shoot actually, I think. Why did all this thing happen? Why,
Sir,
what do you think is the cause?
It was probably because of the underinflated stent struts.
There is a lot of, there is a big calcium plate beyond the stent. The stent is underexpanded. Will that 3 millimeter NC balloon work over here? Do you think?
So we should have used imaging techniques probably.
There is a
With the
calcium
calcium.
plate. So what if you have no financial constraint, what will help here in this patient?
An IVL.
Because even not even cutting balloon, nothing will work actually.
However, we had financial constraints because
Thank God.
Then the presentation is well. Then
presence of mind and operator skill help convert a complication into a bailout bifurcation. Angiography underestimates stent underexpansion of previous stents. Intravascular imaging, like IVUS and OCT, are valuable adjuncts in such cases. Repeat stenting in previous underexpanded stent with calcified vessel have very high risk of stent or balloon entrapment. Intravascular imaging allows a guided post-dilatation with high pressure or specialty balloons. So our steadfast mantra every time should be to not to panic and to retrieve before we retreat. Thank you very much for a patient audience. Good night.